Introduction, then I'll go on mute, and then that'll solve that problem. So again, welcome to Surgery Grand Rounds. We're really fortunate to have Mark Molitor with us today, and he's going to talk to us about something that he's, what I would say, the largest content expert that we have in our group. A little background: most people may know this about Mark, but he's actually a true Phoenician who grew up in the West Valley, went to University of Arizona for med school, and then ultimately ended up in Michigan, where he did surgical critical care and developed his interest in ECMO. And most people know that he's the ECMO director for our organization and has done just an outstanding job through COVID and the growth of our ECMO program, which has exploded over the last 3 or 4 years. In that vein, a lot of what we know about congenital diaphragmatic hernia does involve some component of ECMO in terms of survival and taking care of these babies. I've asked him to talk about congenital diaphragmatic hernia and not ECMO because unfortunately our previous fellow scooped the ECMO talk when he left. Juan gave a talk on ECMO last fall. So after being at University of Michigan, Mark went to Salt Lake City and did his pediatric surgery at Primary Children's, and then was recruited back here to his hometown to start his pediatric surgery practice, which he has now been pushing almost 10 years, I think. 8 years, Mark?
This will be 10 years.
10 years, okay, yeah. So, and I'm really excited about what Mark's going to talk about today, because we'd got a little stagnant in terms of how we were reporting diaphragmatic hernia for a period of time. We were part of the registry, and we've gotten better at that because Mark really thought it was important, and he's driven that. And I know he's going to show us some data about outcomes and also talk about congenital diaphragmatic hernia as an entity itself. So Mark, thanks for giving this talk. We're really excited to hear it. I know it's going to be great, and we'll take questions afterwards.
Perfect. Thank you so much. It is great to be here today. Don't forget to enter your CME code and do all that good stuff through the UOP. And so the topic Dan mentioned, talk about congenital diaphragmatic hernia, and I thought I'd talk a little bit about the evolution of the process here at Phoenix Children's, and mostly over the last 10 years since I've been here. And by no means in any way when I discuss anything today, am I giving bad credit to the previous, before I was here. This was just looking at something that was actually good and how we could make it better as a group. And so Untitled, if you build it, will they come? And look at some data about our numbers and outcomes throughout time. I have no disclosures. Briefly, this is kind of the outline of what we'll talk about today. A bit of time on sort of what CDH is, how we treat it, both medically and surgically. I will talk a little bit about ECMO, just because I can't afford not to, and one of my second passions. Then we'll talk about management and then care here at Phoenix Children's as it has changed over the years. Cdh happens about 1 in 5,000 births, and it's probably a small increase over time, but like all good things in peds surgery, it's about 1 in 5,000. It does seem to be more common in males. The most common defect is that posterior defect that you see here, the Boptelet hernia. 10% of the anterior, the Morgagni hernia, but you can get some other ones that happen, but the most common one is the Boptelet hernia. 80% of the time it occurs on the left side, about 19% on the right, and then you can have a total deformation of the diaphragm where it doesn't form at all. By the way, that's fairly rare, and those children don't tend to do very well. Overall mortality, as we look at this through at we consider tertiary care centers, so that deal with this, is about 20 to 30%, and that is a decrease over time. If we look back probably 15 years ago, the overall mortality for CDH was about 50%, and that has now decreased.
Okay. So Kathy says they don't see your slides.
So, okay, give us one moment. Didn't miss much.
Oh, okay. Okay, where's slideshow here? Okay, we need to get back to Zoom and share screen.
It'd be great if somebody online can tell us whether they can see the slides now.
She says, yay.
Perfect. All right. Again, this is like the second slide in the entire thing, so you didn't miss very much. As I mentioned, mortality has decreased over time. And we look at this completely, there's probably about a 20 to 35% of fetal cases that end in termination or in utero fetal demise that we don't even know about. So There is population there as well. Here we go. There are some associated anomalies with CDH, and they do tend to portend a worse outcome in that. The most common being cardiovascular, about 28% of the time. The most common ones being VSD, ASD, cohort, hypoplastic left heart or tetralogy. There are some urogenital defects, musculoskeletal or central nervous system. And about a third of the cases do have a genetic abnormality associated with them. There are about 70 genetic syndromes that have been described with CDH. Some of the trisomies 18, 21, 13, Sprint syndrome, Denay-Barrow syndrome, Beckwith-Wiedemann. And there does seem to be some autosomal and sex-linked variants that go along with it as well. But the true genetic cause of CDH, we do not know what that is yet. Why do we care? Right, so there's just some guts up in the chest. Well, it turns out that guts up in the chest actually really hurt lung development on two ways. And the things that I care about once I hear about a diagnosis of CDH and that we all care about is the pulmonary hypoplasia and the pulmonary hypertension. In terms of hypoplasia, it's actually a smaller, not only is it a smaller lung, but the lung doesn't develop. So a decreased number in the bronchioles and the alveoli that are there. When you have less alveoli, there's less area for gas exchange to occur. And it doesn't only happen on the side of the defect, I mean, it's left side or right side, but it's the contralateral lung is affected as well. And secondarily, the pulmonary hypertension. As the lung doesn't develop well, the blood vessels inside the lung also don't develop. So there's a smaller number of them. In the fetal heart, even though, and physiology, even though the placenta is doing most of the work, the heart recognizes that it takes a harder amount of, it's harder to pump blood through the lung that is there. And so there's some thought that heart is working a little bit harder, even in fetal development, that then leads to an increase in this prostacyclin and increased vasoconstrictors in the fetal lung bed that then causes these arterioles to be smaller, building up the musculature around the arterioles such that when they're born, we have these, very thin, small blood vessels then that are hard to pump blood through. Once the diagnosis of CDH is made, then really it's the prenatal counseling. So, this used to be like, okay, you have CDH, show up, we'll take care of you when you get here. But we recognize now actually that the treatment of CDH actually starts in the prenatal realm of things. So you have to get the families involved. And so really a multidisciplinary approach to this. And I'll kind of briefly talk about it now, but then go into a little bit more as we develop the program here at Cdh. This involves surgery, radiology, neonatology, palliative care, cardiology, any of the other anomalies as well, genetics, urology, nephrology, neurosurgery, cardiovascular surgery can all be involved. And the process really is a lot of prenatal imaging and then discussing with the families what all this imaging and testing means and what these predictors are for birth. So ultrasound, we use that, so what's going on? Ultrasound is the main one. So, done somewhere between 16 and 20 weeks, most women get their sort of high yield ultrasound that's done. And that's when most of the diagnoses are made. We then bring the patients back, anywhere between 24 to 28 weeks a week. And when we do them in that realm, we can then get some predictors that go along with it that can tell us sort of the severity of CDH. And when I think of CDH, that's how I think of it. I think of it as a spectrum of disease from mild to severe. We get some measurements. The most one we use the most out of ultrasound is the lung head ratio. In the lung head ratio, we're literally looking at the baby's head, the baby's chest out of 4-chamber view of the heart, and then they take some measurements in there. What goes on, and they come up with a ratio. And then that ratio, as we look at it, really divide into what I think of it as into thirds. We have a less than 1, a 1 to 1.5, and greater than 1.5. And in that category, basically, less than 1 is a severe category. Moderate is the 1 to 1.5, and then greater than 1.5 is really a mild disease. And when we take those numbers then and look at them and follow through the Cdh research group, we can actually come up with survival percentages. And within that, again, the worse off you are. So if your LHR is less than 1 and you're in the severe category, your chances of survival are low. Your need for ECMO is high. And when you're in the mild category of things, your chances for survival are higher and your need for ECMO is less. Some of these numbers are a little skewed, and I will admit 44% in the in the data that we had, 44% in the mild group is actually probably fairly high as we look at that. We can also use the ultrasound to predict high drops, again, look at it right versus left. And then what's actually probably more important now is whether the liver is up or not. And when the liver is up, what percentage of the liver is up in the chest that are giving us some actually probably better prognostic indicators. So how do we measure liver up? Now we can get MRI, and I will credit PCH being probably one of the leaders in this and taking it to the next level about getting fetal MRIs. And the benefit is that we can actually see spatial resolution that's going on here now. We can actually use a formula in the computer to sit there, and Dr. Gonçalves and his group will sit and measure the lung volumes that are actually in there. And we can get fairly accurate readings. And then we have regular MRIs as well. So we can compare those, what we have, to what would be expected with a fetus in that gestational age range, and come up with a ratio. And then we can have an observed to expected total fetal lung volume. And again, we can break that down into categories, between less than 25%, 25 to 35, and then greater than 35% from that severe to mild severity. And then within those, come up with outcomes in there as well. And again, so when you have a little bit of lung, your outcomes, your survival outcome is poor, and those are probably less than 25% chance of surviving the process. When you're greater than 35%, you get into that mild case, and those survival in that group is up, as high as 80% in some centers. And I mentioned the liver up. Oops, go back to that real quick. So liver up, they can actually take and measure, volume with MRI. It's actually, so it's total fetus. They can see the whole thing. They can actually measure the entire volume of the size of the liver, and then look to see how much, again, for left CDH, how much the left lobe is up in the chest. Get a percentage of that. And then anything greater than 20% is considered very profound. And those babies will then fall into the severe category of things in terms of overall survival. Fetal echo, looking at cardiac position and structure. And then we can actually get a small predictor of what the pulmonary hypertension will be that using something called the McGinn score. Once they get that index, MMI less than 1 actually says that there's a high risk for pulmonary hypertension. So we can begin counseling the families about what that is. Again, taking this all into a sort of range and into a complex of diet or findings, we can then counsel the families about what to expect once the baby gets here. Is it 100% accurate? No, obviously there's some clinical things that change when they come out, but for the most part, we know we can give the family some expected management, what's going to happen. The remainder of the pregnancy then, and when I said that team, and then who I forgot to list on there was the obstetricians, the maternal fetal medicine doctors, because they play a big role in this. So once we know these predictors, we can then report back to our obstetric colleagues, and they can manage the remainder of the pregnancy as it goes through there. We can make some recommendations for that. We don't tell them what to do. We can just tell them what's going on with the fetus so that they can make the best choices to keep mom healthy during the remainder of her pregnancy. One thing that has happened over the last several years was that there is some fetal therapy. So if we look at the history of CDH, there was they would try fetal surgery. So trying to do a modified exit procedure where they leave the baby on placental circulation. They deliver everything but the head at that point in time and do the repair. It didn't improve outcomes overall for the CDH, and it actually had a bunch of maternal comorbidities that would result from that, resulting in premature labor. And so that was actually sort of abandoned along the way. But there was some thought about what if you were able to block the trachea and let the amnion, or excuse me, the fluid that's in the lungs sort of in there and don't have a way out, right? Because the baby's breathing in utero, and so that fluid moves in and out, and that fluid does play a role in lung development. And so the first group in Europe did something called FETO, or fetal endoscopic tracheal effusion, where while in utero they take and they put a fetoscope in transcutaneously, translacentally. You can see here into the mouth. And then they deploy a balloon into the trachea. That balloon stays in place, usually done about 28 weeks gestation, and stays until about 32 weeks. And then it has to be removed prior to delivery. And when they did that, they noticed that there was actually lung growth, both on the ipsilateral side of the defect and on the contralateral side. And when they looked at overall outcome in those babies with the severe category of things, there probably is a slight increase in survival. Looking at that group of things compared to babies who were not treated with FETO at that group. That study was actually stopped early due to the positive outcome of that. And so in Europe, that's, doing the fetal endoscopic tracheal effusion is actually pretty common in the severe category of things. In the US, we are looking at it as well. There are 5 centers in the US who are doing FETO. And we have sent a few of our patients to Texas Children's. We sent one to Michigan, one to San Francisco along the way, who fall into the severe category and who have qualified for fetal surgery. All of those patients have survived so far, and we are now seeing them back here at PCH and follow up. Again, the range of the management is done by the obstetricians. Really, we just want the moms to be healthy. There is no benefit to having a C-section versus not. If the mom is healthy, she can deliver vaginally and the baby is taken care of expectantly. We do recommend delivery at a center who knows what to do with Cdh though. And so that is the one thing that we do talk with the families about, in terms of making the decision to deliver at a hospital where there is neonatology and where people are used to dealing with Cdh, and that has actually shown to be have better outcomes when that happens. The initial management once the baby get here is really controlling the pulmonary hypertension and physiologic stabilization. And so this is kind of a busy slide and I know hard to read, but basically the idea is we want to control breathing. We want to make sure that the baby is oxygenated, but not at the expense of hyperoxygenation. And we don't want the baby to get stressed out. And so that might involve intubating the baby. It'll be involved using sort of low pressures, high frequencies type ventilation, preferably conventional versus the oscillator, but there are some discussions about how that works. Controlling the hypotension, UA lines of feet or peripheral IVs in order to get fluids in, and keeping the baby as stable as possible, getting them over to the NICU, and really just leaving them alone is sort of the mainstay of therapy, and allowing the pulmonary hypertension to sort of abate and allowing the babies to just to stabilize. What I'm not mentioning here is surgical repair, and that actually is the last thing on our minds. And so once the babies are stable, then we'll talk about surgery. But then the main thing is controlling the pulmonary hypertension. How we control that in the NICU, over time varies, and that is what has changed over the years. That management, in terms of general ventilation with permissive hypercapnia, things that we all use. We don't have to have oxygen saturations to 90% though. You can get them 80 to 85. As long as their pH is okay and their CO2 isn't through the roof. With that, we can control these babies and allow this permissive hypercapnia. And then we actually do better for them in this realm. And the babies have a higher survival when we can allow that to happen. Sometimes they do need some vasopressors and inotropes. And so we, those will be started as needed. And then really controlling the pulmonary hypertension. Then if, just plain old oxygen doesn't do it, then we can start things like inhaled nitric oxide. Depending on the echo results and whether we have RV or LV function, we can start some of the either PGE to keep the ductus open, and then the Remodulin of the prostacyclins in order to help with to control that and relax the vascular bed. Following the OIs, and there's a study I'll show you a little bit that talks about, maybe OI can give us some clues about when to repair the baby as well. And then in long term, if we're unable to control pulmonary hypertension, then we will look at some of the oral or IV medications with sildenafil, the prostacyclins to go on. And then if in all that we can't control the pulmonary hypertension, then we'll talk about ECMO. And this is just a slide sort of borrowed from Dr. Menon, who shows us sort of what the pathway is that we look at in terms of medical therapy for pulmonary hypertension and how it affects the various cells within the musculature of the pulmonary vascular bed. Indications for ECMO really is you can't oxygenate the kid, or you've got cardiac failure with poor oxygenation, and then we're going to go on ECMO. Having to use really high vent settings with PIPs greater than 28 or so, maps on the oscillator greater than 15 to 18. Then those are all reasons to think about ECMO from an oxygenation standpoint. Unable to maintain sats in the 85%, a pH less than 7. Even with those things, though, a pH of less than 7.2, saying that the baby isn't able to compensate physiologically speaking. Heart failure, and some of these do have some heart defects that go along, and there's some controversy about whether cardiovascular defects should allow you to be on ECMO or not. But because of overall survival outcomes, but we'll look at the cardiovascular failure, and then just acute clinical deterioration. Sometimes these babies come out and they just go down fast, and we don't know really what's going on, and so decisions may be made to go on ECMO for ECMO to the decision making and therapy. Type of ECMO, VV versus VA. Well, really, in the end, it probably doesn't matter. What matters is really what your center is good at. There are centers who do VV and they have great outcomes and equivalent outcomes in centers that do VA. There was a trial from the Cdh study group that looked at that, and what they did is they took all the ELSO data from 2000 to 2016, and with about 3,000 infants who with Cdh that were on that. There were 2,400 in the VA group and 838 in the VV group with that, and they were propensity matched and tried to try to control for non-randomization and all that, because this is all just clinical judgment about whether they went on VA or VV. The primary outcomes were mortality and then severe neurologic injury, and then in there some subgroup analysis of timing of repair on ECMO. And basically, in the end, there was no difference. So if we just look at overall survival, that there's and neurologic injury, there is no difference between the two groups. If you needed ECMO prior to Cdh repair, then VA had a slight increase in survival of that. If you did not have pre-ECMO Cdh repair, then VV would have lower rates of severe neurologic injury in that. So that kind of makes sense, right? If you're really sick before you had the repair done, you probably need VA ECMO. If you need it afterwards, you might not be as sick, and so VV probably works. And we know in VV ECMO in general that there is a less rate, there's a smaller rate of neurologic injury that goes along with that. But the clinical judgment and experience really should drive, which method you use. Type of pump has been a discussion in the ECMO world. So in 2005, or so 2009, really 2008, 2009, the advent of the centrifugal pump came out. So we went from the old roller head, pump into the centrifugal pump that happened with there. And in the adult world, the centrifugal pump has been a wonder. But in the neonatal world, there's been this question about whether the centrifugal pump actually causes increased bleeding complications that go along with that. And so there was the same group, Cdh group, then took that data and tried to look at it in the same subset analysis of things and looked at the type of pump that was going on with that VA or roller versus centrifugal pump. Sorry, went backwards there in the whole process of things. And really, in the end, there was no difference. There was no survival damage. There was no survival advantage, excuse me, no difference in severe neurologic injury. The centrifugal pump probably in the early group did, because we didn't know what we were doing and how to use it, I think, and the experience in that is that there was some more red cell lysis in that group of things, so the hemolysis and the complications that go along with hemolysis. But in the end, and if we look at it nowadays, in our last also meeting a few weeks ago, kind of raise your hands who uses centrifugal, who uses roller, and there are a lot of cases that do neonatal ECMO that are using centrifugal pump, and our center included in that. And so, once we get the baby stabilized, whether that's medically or with ECMO, we have to talk about repair. And so, there's multiple approaches to that, and timing is definitely a discussion about, sort of when we should repair it. And this is sort of one slide, sort of looking at things. There's the group in Utah, my hometown, or my training town, that most recently looked at whether OI could be a predictor of timing for repair. And so, in their group, they took their Cdh, single center experience, Cdh from 2010 through current, to look at how can OI be a predictor of timing. And what they found is that the lowest OI within the first 24 hours was a predictor of what your OI was sort of going to be during the entire course of therapy in there. And that if your OI was less than 10 within the first 24 hours, there was no benefit of waiting for surgery in that sort of magical 24 or 48 to 72 hour period that a lot of us think about now. Sorry. That a lot of us think about now, or when they're sick, waiting longer than 36 hours for pulmonary hypertension to stabilize. If your OI was greater than 25 in that first 24-hour period of things, then those are the babies who needed to wait longer. And so I'm kind of coming out with that. And this will be interesting to see how this plays out in terms of timing. The rest of us probably follow a chart similar to this. If we're looking at things where if you have very little pulmonary hypertension, you're going to get fixed early within that first 48 to 72 hours. And if you have bad pulmonary hypertension, we're going to wait until pulmonary hypertension is controlled, which usually is more of that sort of 3 to 5 day range in terms of fixing it. Open Cdh repair via laparotomy or thoracotomy in order to do it. So here's a picture of an open repair. Left side, you can see the liver pulling it down, spleens out there, but you can see the defect up here in this. The thoracoscopic repair in there. And I wish I was this fast, but it's just kind of an idea of showing you what happens and looking in from the chest. So this is, the camera is looking up and really the axilla down towards the diaphragm here. And this is the defect in the diaphragm. And this particular patient has enough diaphragm here that we can actually just do a primary repair. And so this is just showing, again, examples of a primary repair from diaphragm to diaphragm. Or when the hole is big enough, sometimes you have to put a patch in, Gore-Tex or some other synthetic mesh in order to cover the defect. And then this is a particular baby just to show. In this one, we actually had to do an operation in the abdomen a few days after, a little bit after the diaphragm repair was done. And this is what it looks like when you look from the diaphragm, looking up at the chest then, in terms of doing the operation, what it looks like in the primary repair. Open versus minimally invasive approach, is there a difference? And so, again, this the Cdh study group, has taken their own data, what we submit to them in terms of looking at, so another 3,000 patients looking at open versus MIS or minimally invasive repair within there. And really, even in these patients, the only thing they can show the difference in between was that there was a decreased length of stay with the MIS version of things. There was probably a decreased incidence of small bowel obstruction, but there were slightly higher recurrence rates in this group when they looked at things. I think a lot of this data we have to take a little bit carefully in that, when we look at the early repair with patch, we didn't know how to sew a patch in, I think. Overlap, doing the tension-free, leaving it redundant, all these things that probably weren't done in the beginning. And I know that even in my own experience, when I first trained and looking at this, we just sewed the edges of the patch to the edge of the diaphragm. And I think those are higher rates. But as we look in more of our modern era, when we are leaving overlap and putting a bigger patch in, the recurrence rates are much smaller and actually probably equal what the recurrence rates are for the standard repair or the diaphragm primary repair. Patch versus primary, again, this is one group. And again, this was a little bit of, that totally makes sense. That if you have to put a patch, primary repair is preferred. And if you have to put a patch in, you're going to get slightly, worse outcomes and higher rates. Those are bigger defects. They have other things that are going along with them. The bigger defects tend to have more congenital anomalies that go along with it as well. And so your outcomes are a little bit higher, or a little bit worse, excuse me. And you think about it, I'm putting a piece of synthetic in there that attracts attention and makes scars. So having a little bit of bowel obstruction that goes along with that is just part of the process that goes along in there. And so, just kind of proving or agreeing with what we sort of know would happen, like putting a patch in. There are some other repairs as well, besides just the primary putting diaphragm or patch in, and you can do some muscle flaps. And so in Salt Lake City, we trained with the split abdominal wall flap. And the problem with the flaps or the split abdominal wall is you actually have to think about that before you even make your incision. Because if you make a standard and subcostal incision, which is usually about 1 finger breadth below the costal margin on the left side or right side, you don't have enough muscle there. And so you can't do a muscle flap. So you actually have to think about it because your incision has to go down close to your, still a chevron subcostal type incision, but it has to be down at the level of the umbilicus because you have to have enough muscle to be able to rotate it down, very similar to like a garage door closing, and take the posterior muscle, which is the internal and transversus abdominis, and you take it off the rectus, but then take those two muscle layers down and rotate them into the position of the diaphragm. And so if you don't plan that beforehand, then you can't do that. And if you try to do it and you haven't made your incision low enough, then you run out of muscle and you end up having to put a patch in there anyway, or you have a lot of tension and you have a higher recurrence rate that goes along with that. Flat versus patch, it depends who you ask really in the end. And so Sick Children's and Cincinnati Children's each had about 180 patients. And when they looked at their differences and when they looked at their outcomes, there was really no difference in terms of recurrence rates, small bowel obstruction, anything like that. If you ask the group in Utah, then we think that the muscle flap is the way to go. And so they had very high recurrence rates in their patch group compared to their muscle group. And so I will say that I trained doing muscle flaps for 2 years in Salt Lake City and doing that. And again, what I think this really goes to is you do what you're good at, right? And so if you're really good at doing muscle flaps, then you do a muscle flap. And if you're not good at doing muscle flaps, then put a patch in and you will get the same outcomes in the end. You just do what you're good at. In terms of post-operative management, really it's control of pulmonary hypertension. This still goes along with that and making sure that we don't do anything to upset the babies. Weaning the vent, initiate enteral feeds, minimizing any other comorbidities iatrogenic comorbidities that can happen. Some people leave a chest tube in place, some people don't. The main thing is just sort of when to take that out. Some people leave it in place because there is a higher incidence of chyle leaks, especially in the thoracoscopic group. So leaving that in place while you feed in order to make sure that you don't have a chyle leak in there. And then really it's a lot of discharge planning and management that goes along with that. When we look at sort of long-term outcomes that go along with that, really, it would be hard to see, but in this slide up here, the study group, Cdh study group has listed sort of what the defect looks like. So an A, B, C, or D sort of category of things, with D being sort of the largest defects. We're really missing that sort of hemidiaphragm on the side. The D group is the highest need for a patch. They have the highest recurrence rates. As it turns out, when you have a little bit of diaphragm there, you also have higher rates of neurologic gastrointestinal or pulmonology comorbidities that go along with it as well. And so we can look at that as when you have a smaller defect that presents itself to primary repair, you have fewer anomalies or comorbidities that go along with it. And that's shown in this sort of bar graph down here. We look at pulmonary, neurologic, gastrointestinal, or overall morbidities that go along with our defects. We can then take that data and look at it, and we can come up with sort of what it is. And so this is everything from, how long you're going to be on the ventilator to, what your risks of dying are, depending upon whether you have Cdh that needs ECMO or doesn't need ECMO. Back in there, and maybe I should put this back with the ECMO slide, but kind of overall, we look at this, and if you don't need ECMO, chances are you have lesser comorbidities, and so your needs for things are smaller. When you need ECMO, you tend to be sicker, and your needs, post repair, tend to be higher. So can we look at this and come up with a unifying answer as to how we should do this? So the Absolute Outcomes Committee tried. So back in 2015, a group of pediatric surgeons, and they involved other people as well, tried to look at all the data that was out there. And I get it, it's 7 years old now. But they made a first attempt at trying to unify and come up with a standard set of guidelines for how we should manage Cdh. And in the end, unfortunately, it proved that centers should do what they're good at, okay? Because there are no randomized controlled trials out there looking at management of Cdh to tell us that one treatment method is better than another. So we have tons of case reports, case series, some analyses that look at these things. But what they can tell us, is that, what has proven out there, what we can see is that high frequency, low pressure sort of ventilation is the way standard to go. So minimizing barotrauma, that if we can keep the PIPs less than 25, on your PEEP 3 to 5, and keep your your preductal sats in that sort of 85% range while minimizing acidosis. Whatever strategy gets you there and stabilizes the baby is the best strategy. High frequency ventilation, whether a jet or the oscillator, didn't prove to be better than the other. It just proved as an adjunct. And again, if your center is good at using it, then you had better outcomes than those centers who use it only as rescue or intermittently. Okay, nitric oxide, we all use it, right? So it doesn't matter. We have pulmonary hypertension in a patient, we put nitric oxide on them. Again, there's no randomized control trial that tells us that nitric oxide is better than no treatment at all. In fact, there are some studies that might say nitric oxide is actually worse. In Cdh, the studies which say it works as a transition, meaning that if you have a baby whose pulmonary hypertension is under control, it works as a bridge to either get them onto ECMO or another type of treatment in order to control the pulmonary hypertension, but we use it, right? And so there's no evidence for it. The sildenafils or all of our treatment for pulmonary hypertension, again, it's not that it doesn't work, it's just that there's not randomized controlled trial that tells us that there's a benefit above any other treatment along the way. Okay. Corticosteroids showed no benefit in the antenatal. We use steroids for lung development and that, but there was no benefit shown from that, nor in the postnatal period, except in those patients who are proven to be adrenal insufficient, in which case you can use steroids to help with their blood pressure control. Mode of ECMO, again, looking at the data present at the time, and the other studies I showed you looking at the BA versus EB actually came after the 2015. And so even back as early as 2015, there was no survival benefit to BA versus EB in the studies that were available. In terms of length on ECMO, there used to be this old adage that if you were on ECMO for more than 21 days with a Cdh, that you weren't going to survive. That's probably not true. But there is the survival probably does drop off after about a month. So when we look at patients who are on Cdh patients who are on ECMO more than 30 days, actually survival does dramatically start to decrease at that point in time. And so while we would never probably pull a baby off, I think that there are a lot of discussions that begin happening once we get to that 1 month time frame in terms of overall care of the baby. Length on. Optimal technique, open versus minimally invasive. Again, it's probably comparable. There was some data that looks at the patch repair, because of the thoracoscopic having to use CO2 insufflation, that they had slightly higher PaCO2s intraoperatively, resulting in lower pH. But the data really was, not conclusive on that. But what they did find is, and again, kind of goes along with what I talked about in terms of the initially sewing the patch in, tight, versus making it domed redundant with overlap was the better method. late or repair, in terms of timing, honestly, again, it's what your center is good at. And so when we look at, timing of repair, going back to that chart, 24/76, in there on ECMO, do you repair as soon as you go on ECMO? Do you repair when you're ready to come off ECMO? Do you repair off ECMO? Honestly, again, what your center is good at is what you should do, because there's no data that suggests that one method is better than the other. So we'll shift gears a little bit. And so that's the treatment of CDH and kind of how we think about it. And we'll talk a little bit now about what's happened here at Phoenix Children's, in the last 10 years with things. And so really what we've gone to is this. We've developed this multidisciplinary team of specialists that provides care in every area. So starting in pregnancy, to delivery, to the inpatient stay, to the outpatient follow-up. And it's this whole multimodal effect that takes place really early, and and now we're following these kids. I'm seeing some patients in the Cdh clinic that he's in the room, so I'll pick on Dr. Trika, that he fixed back when he got here, and they're teenagers now, and some of them are even ready to start having their own babies. So sorry, 8-year-old, in the process of things. But I think that's the clinic we built, and where we are with things. But how did that start? So in 2013, when we got here, we looked at this, within even our own surgical group, they were doing about 10 CDHs per year, which is a high volume center. Anything more than 5 is considered a high volume center in the CDH world. And the survival, when we look at it, was about 50%. This was based on a cohort of patients that we could find, in the data that were done here at Phoenix Children's, done at St. Joseph's. And then at the time we were covering the banner for Good Slam ICU to look at that. So obviously this is, I will admit, incomplete data. We don't have it all, but when we look at it, this is what we found. And we thought, and at this point in time, survival had switched. So the guidelines, and I'll show you in 2010, had recommended sort of a treatment algorithm that we weren't necessarily following here. And we were getting survival in the 70 to 80, and that's when the survival started going up in that 70%. And so we recognized that we probably weren't doing as good of a job, and we needed to do a better job. So what did we do? So I will say that there was a group of us, and it was Dr. Egan, myself, and Dr. Ramachandrappa, one of our former neonatologists, who spearheaded this and said, all right, we have the same surgeons who are operating here at PCH and then now only at St. Joe's, and we're taking care of these really sick kids. The only difference is the neonatologists. And while the neonatologists were the same group, meaning that they belonged to the same entity, they were different people. Right. And so the neonatologists that worked here at PCH were different than neonatologists who worked over at St. Joe's. So if we could come up with a way to standardize it so that our neonatologists here and there were doing the same thing at the same time, in the same time frame for caring for these kids, then maybe we can make a difference. And as I mentioned, that in 2010, the European equivalent of the Cdh group came up with their consensus guidelines. And believe it or not, so Europe is really good at getting all the countries, intercontinental, to really come together and come up with the guideline, and that they all followed and did randomized control trials and looked at that. And these were basically the things that they said. So delivery at 39 weeks, avoiding neuromuscular blockade during delivery, the preductal stats in the 80-95% range, a targeted CO2 with permissive hypercapnia, conventional mechanical ventilation is initial strategy. And then they actually did say use IV sildenafil. And when they did that and switched their practice, their outcomes markedly improved. And so we said, let's do the same thing. And so we came up with our first version of the neonatal management protocol, which is not novel. Other people have had strategies before, but we fit this for what we had here at our group and looking at things and employing those strategies. And then we deployed this to both our got buy-in from the neonatologists here, and we got buy-in from the neonatologists over at St. Joe's. And what was unique probably to us was that this was the first time that our group also looked at it and said, okay, but if you're a really severe CDH, maybe we should look at other things. And instead of doing things to the baby, maybe we should look at how we're doing things for the baby. And not only that, how we're doing things for the family. And so we came up with a set of guidelines that actually looked at the severe category of things. And if we couldn't ventilate a baby, meaning get their CO2s under 100, if we couldn't get the pH up, things like that, then those are babies who in our group right now weren't going to survive, at least within our current means of technology and our current means of care. And then got really involved in the palliative care team with those babies. It wasn't a lot, it's maybe one in the entire group, but it was an important step in our process in terms of looking at this is how are we taking care of the babies instead of, and doing things for the baby and the family versus doing things to the baby in that process. And then I will say in this whole time frame as well, and many of us know the fetal care program here really took off. And so Dr. Van Leeuwen and the group, sort of had this idea, we weren't taking care of the babies over at Good Sam anymore. And we saw a little drop off in our numbers in general. And so how could we go out to the community and really tout what Phoenix Children's was doing at that point in time and sort of building our care process? And so, we got the fetal care program as we know it today. We started in infancy, around 2015 or so, hiring a couple of coordinators and really pulling a few people from all the various subspecialties in to say, what can we do to take better care of the babies? And so along this time, in 2017, we sort of updated our process, but really updated the whole management process. So again, going back to my earlier slides where we took this whole prenatal evaluation and put it down into an algorithm that said, look, when an obstetrician in the community gets a baby and they do their high level ultrasound, they get a diagnosis of Cdh, what do they do? And so we pass this around, and again, it's hard to read, but you can see there's a number, and it says if you have a baby with a Cdh and you're concerned, refer them to us. We're not taking the baby away from you. We, how you deliver and manage and take care of the mom, that's really up to you. But we can then give the mom at least, or the family, some information about what Cdh is and what's going to happen with their baby. Look at that, and then have this whole process for how we would refer to various subspecialties, depending upon what was found. And that pathway became even more onerous and complicated as you start looking at ultrasounds and adding MRI into that. And then, when they fit into our mild, severe, or, category of things, who do they get referred to in terms of looking at this? But this whole process that, is subsequently developed to come up with this plan of how to take, this multi-specialty care for the families. In 2018, we updated our protocol. There's some new data out there. We had the outcomes from the new study groups, from the Cdh study group, like things. So, mild adjustments that were made to this. Around this time also is when PCH begins to think about how we're going to run our NICUs and what's happening there. And there's a big transition in our NICU care in our current group with Dr. Martin and Dr. Elquad and the team sort of come in and begin taking over our NICU here. And then subsequently in 2021, begin managing the NICU over at St. Joe's as well. So I would tell you, when you have a cohesive group, you have a group that then has a similar like mind about how we're going to take care of patients. It's amazing what you can do at that point in time, because you can all come together and then you can form multi-specialty teams that do things all at the same time. And so in 2018, we initiate the Cdh rounding team. We get buy-in from neonatology, we get pediatric surgery, obviously we're invested, cardiology, we have a dedicated pharmacist, the NICU pharmacist, but obviously she's dedicated this whole process of things. And then we get buy-in from pulmonology and nephrology, which are our two most frequent consults in the neonatal period, to say, all right, we get a baby with Cdh, we're all notified, doesn't matter whether it's 1 o'clock in the morning or not, we all get notified of the process that there's a baby there. Then we all plan to meet at 8:30 in the morning at the bedside when that baby gets there. And if there are problems before then, they can call any one of us that's on call for those specialties, and we will come together at 2 o'clock in the morning if we need to, in order to manage the patients. And so we start these daily multidisciplinary rounds. They occur every day at 8:30 once the baby is born, until honestly the baby reaches a point where we feel that they are no different than the standard NICU baby. So after repair, and they're at the quote feeder grower stage, and then we'll all say, okay, now it's time, we don't have to meet anymore on this particular baby. We can take a step back and let the NICU manage them the way they normally would. We refine the protocol again, and as you notice, every iteration, it becomes a little less sort of complicated, and there are the things that we felt are really important, really stand out now in the protocol. And this was actually, we just revised this a few months ago, now looking at that in terms of our initial management guidelines for that. And I will tell you, this has gone out to almost every hospital in the greater Phoenix area and around, because there's a process in there for even if you don't know, right? So a mom walks in, delivers a baby, and they find that the baby has Cdh. Now even our local obstetricians can, and neonatologists, nurse practitioners, whoever it is, pediatricians, can look at this protocol and say, okay, if I do these things and manage it up front, I can buy the baby some time until I can get them transferred to that tertiary care center, which is either here at Phoenix Children's or at one of the other local hospitals. Okay, and we do this. And as it turns out, we actually, and I will pick on Dr. Nitric again because in the room, we actually found a flaw in our guidelines right after we wrote them and published them out there again. Because what happens when you have a baby who we know has a DH, but has all their predictors that are really, really good, right? So we're planning for the worst babies in this case. We forgot to plan for the babies who come out and don't know that they have a diaphragmatic hernia. And so we'll have to make some revisions to the guidelines here as well as we go through. But in this time process now, we've been thinking about how do we take care of these kids once they're ready to go home. And so we've created this new Cdh transition to home team. And really, it's a group of RN and MA coordinators who meet the patients basically as soon as the families get here. And they meet the mom and dad and the family, and they work with them throughout the entire hospitalization, just even as a point of contact or as a sounding board to set up what's going to happen when their baby goes home. Come to the Cdh clinic, come to the neurodevelopmental clinic, and whatever the other appointments are. And they all get this, and hopefully it turns out a little bit here, but they get this sheet that says, what they're expected to do and kind of give them an idea that their baby with Cdh is going to need follow-up and pretty extensive follow-up, and when that follow-up needs to happen. And then down here on the bottom are the numbers to call. Again, the three most common used are pediatric surgery, cardiology, and pulmonology. And so those are the numbers to their clinics or their call service so that they have that readily available to them and can call 24/7. Okay. The long-term morbidities, if you go again, that slide that looked at all of those things that can go on in a baby with Cdh, and in there. And so how do we follow all that and keep track of that? And so honestly, what we did is we developed a Cdh clinic. And so myself, Dr. Menon from cardiology and Dr. Williams from pulmonology, agreed that, again, as the top three specialties involved with that we would come together and we'd have it's a once a month multi-specialty clinic. I did put Glenda Gilbert, she's our RN coordinator for the clinic on here as well, because quite honestly, we couldn't do this clinic without her because she arranges all the patients to be in there. But we see them. And, we started this process in about 2017 or so in there with the Cdh clinic. And honestly, it was pretty boring. I got to know Dr. Menon and Dr. Williams really well because we hang out together to see one or two patients. And slowly, but now we have over 100 patients involved in the Cdh clinic. We're meeting once a month. There's on average 10 to 12 patients per clinic that we see that need all of these things. And then we can not only follow their, the local outcomes from cardiology, pulmonology, and then the recurrence rates, but then get them referred to their other subspecialties as well. The NEST clinic has really taken off, as well as the neurodevelopmental clinic. So all of our babies that we know about, at least born here, are automatically referred to the NEST clinic and followed for their neurodevelopmental outcomes. But not only it's the patients born here at PCH, but other patients born at other hospitals who are taken care of, at our local competitor, end up getting referred to us. And so we see them as well. And we put them into the NEST clinic right away. And so just this whole collaborative group that now has built this whole process in order to take care of our Cdh patients. So what has that done? So if we look again, go back to our overall survivals and mortality, back in that 2012, 13 realm when we got here, we had about 50% mortality in here. We started our kind of first program or first iteration of those guidelines back in 2013, 2014, and we saw, some decrease in mortality at that point in time. 2015 was a weird year. We had about 10 Cdh patients and none of them died that year. And so, it's a little bit odd, but if you look at our trend line, we come back up. What really happened in there is that between 2014 and 2016, as we put our guidelines into effect, we get buy-in from both institutions. Again, that's both PCH or PCH Children's and St. Joe's, the different neonatology groups that are there, different neonatologists that are there. We get buy-in from that. They follow the protocol to a certain extent, but our mortality immediately drops. Now, whether that drops because of the protocol or that drops because we're paying attention to it, and we actually have a multidisciplinary team who's beginning to take care of these patients, hard to say, but the protocol is there, right? And so we see this effect. And then in 2019, again, as we get our second sort of group in here, when we take over when Phoenix Children's takes over these NICUs and we have a cohesive group, it's the same group of neonatologists that are both at Phoenix Children's and St. Joe's, following this protocol, we get our second drop in mortality, such that we're hanging out probably around the 10% to the 10 to 20% realm at this point in time. If we take this in sort of epochs, meaning that if we look at 2010 to 2015, our overall survival was about 60%. Okay, when we look at that, we look at those numbers and survival, not mortality. So 40% mortality within that group of things. If we then take that second group and go 2017 to 2020 and looking at it, our overall, our survival goes up into the 85% realm of things. And that's all comers, I'm not stratifying that based upon mild to severe conditions, but our overall survival in this group goes very high, the 80 to 85% realm of things. Now, and I'm looking at some of my partners in the room here and they're thinking, we have some really sick kids. When I will tell you during that time frame as well, and we're working on the data right now to make sure it's clean. I don't have the exact ones to give you, but our LHRs during that time were very low. We're in the less than, the majority of our patients are 1.3 and lower. So meaning that we're in the more sort of moderate and severe category of things, and those babies are surviving at Phoenix Children's Hospital when they used to not. Okay, and we can compare those to some of the published data out there from a couple of centers who say that they are the best in the world at taking care of these Cdh, and having these survivals at 80 to 90%, and we are as good as they are. Cdh and ECMO. So if we look at the numbers, and this graph, but I didn't share on the other one. So this is the white is looking at sort of total number of Cdh taken care of by year. And already in 2022, we have taken care of 10 Cdh patients within our system. Okay, and then sort of the red shows you the number of patients that were put on ECMO at that point in time. So ECMO, we don't use a lot of it in Cdh anymore. And then the number repaired on ECMO. And then what I can compare in the next group is sort of what our mortality is based upon our overall mortality. And in 2019, we didn't have a great year. We lost all of our patients that were done on ECMO that particular year, and same thing in 2014 and 2015. But again, 2020, 2021, 2022, we've had several patients that have gone on ECMO, they survived. What I will tell you that happened in 2020 in terms of changes is we changed how we do our bleeding protocol on ECMO. And so we made a bunch of changes to that. And so our bleeding morbidities decreased significantly, which I think has led to some of our, decrease in mortality as well while on ECMO. So we've taken this system, we've built it along. And so the title of my talk was, if you build it, will they come? And so the answer to that is yes. And so what I'm showing you here is the number of referrals for Cdh patients that have gone into our fetal care center since 2014. So if we look at, it's not that we weren't seeing patients back before the fetal care center was developed, we were, right? So they get a diagnosis, they would call, or at the time, the pediatric private practice office, and we'd get in and we'd see these prenatal consults for Cdh. And then we get our fetal, honestly, the fetal again around 2015 in there as we start developing the fetal care center. And then we can just watch the number of referrals go up. Interestingly, in 2019, as everything else, there was a decrease in the number of referrals that came in during that year. But then right back up in 2020, a little small decrease in 2021. But again, the trend line that sort of looks here is that we are continuing to go up. There have already been 22 referrals for Cdh in the first half of 2022. That we've seen as a process and sort of growth of our center. So where are we going with Cdh care? I really think you have to divide that into two processes, right? So I think that there's the future of treatment for Cdh, and then there's going to be the advances in our own local program and sort of what we can do. So looking out there and looking at the literature, so what are the advances in Cdh care, or where are we going to go? And I think that actually comes in two realms. I think it's FETO, or the fetoscopic endotracheal effusion that's been going on. So proven some efficacy in the severe group. Right now, the trials are actually looking at that moderate group to see, and they are randomizing patients and that to receiving FETO if you fall into the moderate group. And right now, the preliminary data would show that in the moderate group, if you fall into an LHR of less than 1.3, so in the more severe end of the moderate group, that there probably is some benefit to tracheal occlusion in terms of lung development and decreasing pulmonary hypotension. Stem cell therapy. So the group in Texas right now is looking at stem cells. So if they can take cord blood, they can filter out the stem cells that go along a specialized form of the stem cells. They can actually inject those into the lung that will simulate lung growth in the process of things. And so preliminary work all in mice so far, but I think that's the translational research that will be coming along over the next several years. Sean Kunisaki at Duke is looking at stem cell research also, but he's looking at growing a diaphragm. So you have a baby who has a diaphragmatic hernia. They come out, you take the cord blood, you filter out the stem cells. He then takes those with a little piece of muscle tissue, and then he can stimulate that to grow into a diaphragm so that you take and you give the patient basically their own muscle as a patch. I mean, it's a patch right now, right? It's not a functional diaphragm, it's a patch, but it's a muscle patch that theoretically will develop a blood supply that can grow with the patient, and so hopefully decrease the recurrence rate. Within our own program, I think the areas that we're going to see growth, so Ecmo Transport, right? So we know that a lot of, well, even though we recommend that these babies are born in a tertiary care center, and for us, that means St. Joe's within our system, but they're not all born there. And sometimes patients don't know they have a Cdh and they're born on the outside, and those patients can get sick. So can we go get them? Not only can we go get them, but if they're really sick, can we put them on ECMO there and then bring them back to PCH? And I will tell you the answer to that question is yes, because I've done it in the last year, in fact. And so, the program is there, and buy-in from administration and just the growth, neonatology and all those other specialists, that we need to grow our program, and we need to be the leaders in terms of taking care of these babies within our own state. And then just in outreach, right? So what? So we're taking care of these babies, but what happens to them in the end? And so Dr. Van Leeuwen is looking at a study now where we look at access to healthcare. And so which patients are actually using our system, right? I know, so I have 100 and some patients that are following me in Cdh clinic, but I can tell you, we're not following every patient that we've ever seen and delivered here or taken care of. And I know that because I gathered data from, looking at our numbers in Cdh. I saw a lot of names and thought, I've never seen that patient in Cdh clinic. And so I think there's a lot of outreach and follow-up that we can do, and we'll look at that and the health disparities that go along with that in terms of developing our program. I would be remiss if I said I did this alone, right? So I think, and I left the picture out of here, I forgot to put Dr. Egan in here. And then also a blank space because I need a GI doctor. So GI needs to go in here as well, in case you're listening. But really from neonatology, Dr. Bhopal, Dr. Martin, Dr. Elquad, Dr. Williams from pulmonology, Louise Goncalves and his team from radiology, looking at things, Karen Papez in nephrology, Sharad Menon, and then Rhonda Kurz is our NICU pharmacist that really works with us. And honestly, we couldn't have done any of this without sort of buy-in and help from each of these people. And then our sort of fetal care coordinators. And so Abby and Noel are two, they're the RN and the MA coordinator who go to the NICU and meet these families and follow them and really stay involved the entire time. Tiffany is actually on the cardiology side, but as I've mentioned, most of these Cdh babies actually have a cardiac defect as well. And so Tiffany is really working with us. Jessica's our original fetal care coordinator, and so now it's the manager in the system, but really helped take it off. And then I will say that I'm a lucky guy because I got to work with Alicia twice. And I could never have done this without Alicia, to be quite honest. Not only from the ECMO side when I first got here and developing the ECMO program, but now as she transitioned and is now one of our fetal care coordinators, I mean, she honestly is the face and voice of the fetal care program. So she sees pretty much every Cdh that comes in, has been responsible for over these last several years. And so again, I give the kudos and the team building approach to to these 5 women who really taken it over and manage it. And with that, I will say, are there any questions?
So when they're doing the fetal procedure, how risky is that for the mom and the baby?
The question was, in the fetal procedure, what are the risks to the mom? And so the biggest risk, they are sedated, so it's an anesthetized procedure, so mom is anesthetized for it, and baby, and almost enough to make the baby anesthetized. The baby is anesthetized as well. So the biggest risk to mom is actually premature rupture of membranes. And so there is a higher incidence of premature delivery in the fetal group compared to the non-fetal group, obviously. There are some things that they've done over the years to change the anesthesia to try to minimize that, but it is an irritation to the process. And fetal can't be done with a really anterior placenta, and so they can't go through it. So there are some limitations to how that can be done as well. Jacob.
So you briefly went over and said that the results for patients on VA are going worse than VP. And for the neurologic outcome. And for years, like what we've been saying, oh, you can ligate the carotid artery with no impunity, but in some ways that kind of goes against them.
So the question is on VA ECMO, that there's a slight increase in mortality in that group, and neurologic injury, I should say, with that particular group. And because we ligate the carotid artery, is there any evidence to suggest that we shouldn't be doing that? And the real answer is we don't know, right? So the most recent studies out there say that there is no difference in neurologic outcome when ligating the carotid versus not. And that's just particular studies looking at that. It'll be very interesting because the group in the UK And we try to do that here, which is really hard. And maybe we still can, but the group in the UK will probably publish this data first. So they are looking at the Cdh consortium for all of Europe. And they have been able to get their data, look at ECMO, non-ECMO, carotid ligation, carotid repair, and they are now following these patients. I believe they are going to publish their 5-year follow-up, so the kindergarten data, probably next year is what Dr. Viscotti told me when I was talking to her at ELSO a couple weeks ago. And so, but it'll be, so that's great. So we'll have that. And so I think we'll get our first glimpse at that answer. It'll be very interesting is because they also have patients who are now in high school in the process of this as well, to actually give us our probably first look at what the true developmental outcome is of ligating the carotid artery. The group, there's a group in Atlanta, Texas Children's, obviously with the Cdh study group. We're trying to get that data here, but as you can imagine in the US, it's a lot harder to do and follow up and to get people to participate. It's hard to get people in the US to participate in multi-institutional studies and give up their data. Yes, sir.
If there would be any role for telemedicine, maybe sort of on these once a month visits to try and continue to keep in contact with these families, in addition to the numbers that are on the like handout.
So the question was, is there any thought in terms of our outreach and developments in terms of using telemedicine? And actually, that's something I forgot to mention in the whole process. So we actually do. So most of our fetal, so I'll go through the whole gamut of things. So most of our fetal counseling groups that go on are actually by telemedicine. So making it easier for families to join. It also allows us to be able to have these conferences at 7 o'clock at night if we need to, because that's what's convenient for the family. And again, buy-in from the whole group. So in terms of being able to do this. And I will say that my best one yet so far from prenatal counseling was that I was meeting with a family recently who were here in Phoenix, obviously for the mom and dad, but grandma was from India. And so she was zooming in from India to join the conference while we were doing the prenatal counseling. But we do use Zoom, as CH has adopted Zoom here. So we use Zoom in the interim as well. And so even for Cdh clinic, we will use Zoom. The coordinators, the MARN coordinators, keep in contact with these families either way, phone, Zoom, in person, whatever needs to be done. So we are utilizing that. But I think there are other ways to utilize that in the future in terms of keeping in contact with the family. So definitely something we are looking into. Dr. Eden.
All right, thanks a lot. Wonderful review of what seems like a bunch of a lot of very major developments over a relatively short period of time with this program. And when we get to the point where we're talking parents mainly for a couple of years after repair, what is the difference in how we are talking about recurrences versus like a lot of other surgeries that we do that recurrence is like a 4-letter word in most of the surgeries we do versus recurrence for a Cdh?
So since I think the question is how do we counsel families, both prenatally and post repair for the risk of recurrence? And what I would say is that most of us, I think, in the prenatal, I don't do all the prenatal counseling, obviously that's distributed within our group. I think all of us go over that, right? And we just sort of say recurrence is happening. What I will say that we talk about in the clinic, or at least the one that I see, like in comments on, is I don't use it as a 4-letter word with that. I just tell them that it's part of the process. So it's development, right? So they didn't develop a diaphragm. And so we gave them one, or we gave them a separation between their abdomen and their chest cavities. And sometimes it grows and sometimes it doesn't. And so we just have to follow that. It's part of the process. And that at some point in time, we likely will have to do another operation. And so setting the expectation that they may need another operation without the fear of oh my gosh, I gotta, he sniffled, so I gotta take him in and look at this from a recurrence standpoint of things. And so I think it's all about setting expectations. And I know that that's what I've done. And from what I can gather is that by the time they come see me in Cdh clinic, I try to send all of the patients at least a few times to see the primary surgeon before we, sort of get them into the Cdh clinic. And I will say that when I had that conversation with them, all of them have said like, oh yeah, Dr. Egan told me that, or oh yeah, Dr. Chica, or Dr. McMahon, somebody, they've all said like, oh, that's what they told us before. And so I think even within our own group looking at that, we're already doing that counseling to prepare them for it.
Okay, we're over time, but we got one last question, and this one's short. Excellent talk. Are we recruiting for a fetal surgeon for a fetal?
That is beyond my pay grade. So, all right, thank you so much, everybody. Have a great day. Trying to hit end up here.
Sure, yeah.